that the mood is one that can perhaps best be described as anxiety and uncertainty as to how things are going forward. And I think that's absolutely natural, because we're going from an environment that we understand, sort of healthcare 1.0, the way we've lived it, those of us who've been in practice for a number of years, to version 2.0, which is really incompletely understood. And it's incompletely understood for a very good reason. It hasn't yet been written. Yes, the ACA is out there, but for about every page of legislation, there's 20 to 40 pages of enabling regulations. And those regulations have only partially been written. And some of them that have been written are still in comment period and will be changed further. And some that have been written and issued will be changed. And so we're in a process where, as we, the Academy, try to keep our members up to date, it is in flux. Now, I think there were some people who may have thought, quite frankly, that if we were in a Mitt Romney presidential period versus a Barack Obama presidential period, that things would be dramatically different. I think that none of us really thought that was going to be the case unless there was really total control by the Republican Party of all three houses, and hopefully, for their sakes, if they were in control, a filibuster-proof majority in the Senate, because we all know that there are really two basic schools of approach to healthcare reform. One represented on one side of the aisle, one represented on the other. The reason that it was going to take that, and the reason why we, and I say we, I think I speak not just the Academy, but the House of Medicine generically, expected that we were going to see reform moving forward, is that the drivers of change are there. They've been there since the beginning, and if anything, they've only gotten more significant. And we all know that the biggest driver is cost. Right now, we have healthcare consuming 16+% of GDP and rising. That's unsustainable, particularly when you consider that at an individual basis, which is the way, of course, that many politicians and policymakers look at it. A typical American's after Medicare healthcare costs between age 65 and death is about $300,000 to $500,000. The average American has $61,000 in his or her retirement account. To say that this is something that we can sustain and yet even let it get worse, just as unrealistic. So we have this huge cost driver. We also have quality issues, we have access issues. So yes, if it had been a Republican White House, there would have been changes. Would it have been monumental change? Probably not, again, unless there was total control, which I think none of the pollsters ever appreciated. So we, the profession of ophthalmology, we, the major organizations in ophthalmology and in the rest of medicine, have always assumed that we are going to be undergoing a major period of transformation. The issue then is, what can we do as a profession, as an academy, to advocate effectively for ophthalmologists, for the patients we serve, to represent our profession in the best way possible. And yes, there are some things we can do. There's no question the American Academy of Ophthalmology single-handedly can't change the individual mandate. But there are a number of things embedded in the Affordable Care Act which are vision specific, that we will have the opportunity to affect the wording of the enabling regulations. So our goal is to help our members understand the changes that are happening, give them the tools, the models of care, if you will, to succeed and thrive as best they can in what is going to be a very changing environment. Is it doom and gloom? No, it isn't. All of us went into medicine because we want to take care of patients. We're still going to have that privilege. We still, at the end of the day, are going to have the business of practice to run. Yes, more of us will be employed by hospitals, more of us will be in big groups, but at the end of the day, we are still going to have a business of medicine to deal with. And we have to figure out how to develop systems that will permit us to give more value than we have before, because that's going to be the way to really optimally succeed going forward.
Thank you, Dr. Park. Dr. Retinal.
Thank you, Ronaldo. Thanks, David, for those comments, and welcome to everybody who's here. I guess I'm in the unenviable position of talking about some of those business outcomes that we're dealing with, but I also want to second what Dr. Park said, that in fact, though I'm sitting here talking about financial and business things, we do, as physicians, care very much about the patient, and it's not just about the dollars. There are probably three issues that our members are concerned about here that are acute, and probably many that are a bit longer term. The first, and the one that came out on Thursday that I'd like to address, is the physician fee schedule. That's, of course, the annual event in which we find out how much payment is going to be raised or decreased for the next year. Last Thursday, the final rule was published, and there are several important things that we need to be able to communicate to our members from us, but also to your readers and to whatever source or whatever media version you're providing. The first, and I think the important one, is the value of cataract surgery is being reduced by the payment for cataract surgery is being reduced by about 13.5%. This is not a value estimate because we live in a relative value system where the dollars that are there are simply divided, and changes in how cataract is being done is changing or driving a change in valuation. So one of the communication problems that we have, and everyone has, is that cataract surgery has gotten better, but it's also gotten faster. And the rate that, or the time that it takes a practitioner to perform a service is a very important, integral in fact, to the value that that procedure gets from CMS in valuation. And the value went down the time went down from 35 minutes to 21 minutes. Those are probably real times, and that changes the amount of payment that you can drive out of that procedure. It's not a system that we developed, it's a system we play in. It's one that CMS mandates. It's done in cooperation with the American Medical Association. But in the end, CMS chooses the data, and the value is driven to a large extent by time. And that's important for our members to understand. There are also other somewhat more in the weeds effects on cataract, but for the most part, we think that as time has gotten better, the procedure has gotten safer, the amount of money that's paid for it has gone down. Will that happen again in the near term? No, that procedure won't be revalued probably for a minimum of 5 years. But members are asking, they're in fact worried. In fact, I was told by several people, is it a rumor that cataract surgery is being reduced? And of course, it's not a rumor, it's the truth. The other issue that has come up in the fee schedule that is new and different is that for the first time, when ophthalmologists perform 2 laboratory or 2 ancillary tests in their own office, so they do an imaging study like OCT and a visual field on the same day, the less expensive of those tests is going to be reduced in value by an amount. On average, that reduction turns out to be about 3% of the total price. So that if you did those 2 tests on a given day in 2013, you can look for an aggregate charge reduction of about 3%. It's a small but significant impact across all of the medical space. These are important reductions. I also want to remind everyone that payments from Medicare on top of the fee schedule have increased to ophthalmologists. Ophthalmologists have been very successful in participating in e-prescribing and PQRS, and in fact, it almost counterbalances the effect of the testing reduction, so that by getting the bonus for e-prescribing, by getting the bonus for PQRS, is a way that practitioners who are participating in those programs have offset and will continue to offset those losses. There are other minor changes in the fee schedule this year, but they pale in comparison to these two. I should say that obviously the nature of one's practice, those reductions are going to affect different parts of our membership differently. The cataract surgeon will, of course, take a large hit because of cataract surgery, but the subspecialist doing retina, who does a lot of testing in the office with fluorescein angiography or OCT or photography, will see those cuts affect them, even if they do ultrasound. So this is going to be diffuse, but not even in terms of its penetration. Now, that's the one thing we now know what's going to happen. So that at least some planning for that. But there are 2 other cuts that are looming. And of course, you can't turn on the television now or open the paper, or the NPR this morning was talking about it, New York Times is talking about it, and that's what the government's going to do in the next 8 weeks before the end of December, when they have to solve either or prevent the SGR factor rolling in, which right now in the fee schedule would be a 26.5% reduction in payments on top of the other reductions that I mentioned. Now, the SGR is not something the American Academy of Ophthalmology can single-handedly solve. This is one where medicine, and to be honest, patients can be very helpful to us. The beneficiaries, I think, would recognize and will recognize that that kind of cut will change access. But that's one the House of Medicine and the Congress, I think, are committed to solving it, at least in a short term. We don't like short-term fixes of SGR, but if that's what it takes, we're certainly not going to decline it, at least not at this time. Is it our policy to decline a short-term fix? But we believe that it's in the interest of medicine and ophthalmology to see a longer-term fix for us on SGR. The other is the sequestration, or the 2% cut on discretionary funding in the Medicare program. This is now a 3rd cut, if you will, that's going to affect ophthalmology. And that's one that's perhaps as worrisome in how Congress will manage to deal with sequestration at the same time that we have tax credits or tax exemptions that are going to be expiring at the end of the year. In other words, you have the fight between the 2 parties on exactly what mixture of increased taxes and or reduction in benefits that can lead to some kind of agreement to avoid sequestration taking place. So it is possible we could be sitting here in 8 weeks and all of medicine could be looking at tremendous cuts. They'll make the small dollars on the cataract and on the multiple procedures look like nothing. The reality is, I think that our lobbying team and all of medicine is lobbying on those issues, and I think we all expect that there'll be some kind of relief. We just don't know how much. And a member asked, well, will they let any cut take place? And I think that we don't know. It certainly would be tempting to say that everyone should bear some brunt of this, and we'll let the doctors take a little bit. On the other hand, they may not. I think it's simply unknown right now. Only one time before has a cut been let go into place permanently. I think it will be upheaval in the offices, though. I think that as in other years where we've had these late changes, the claims processing, the claims hold that go on really disrupt the business aspect of running practices around the turn of the year. I think that those are certainly some initial comments. I look forward to the questions when we get to that point.
Thank you, Dr. Remka. Over to you, Dr. Copeland.
Thank you, Ronaldo. Thank you, David. Thank you, Michael. And hello to everyone here that's seated. I'm going to talk about the projected workforce deficit that we expect. It's expected that we have approximately 90,000 shortage of physicians by the end of the decade, and approximately 136,000 to 159,000 shortage of physicians by the year 2020. So we're looking at a deficit of physicians, and you're probably asking yourself, what is the driver for this? The major driver for this is the population. The aging population is growing. The United States Census Bureau has estimated that between 2006 and 2025, there'll be an increase of anywhere from 50 million to 350 million individuals in the United States. So the population will be growing. As the population grows, we know that approximately 39% at 2020 will be 65 years or older. We know at 2030 we'll have probably 79% of the population will be 65 or older. And we know that anywhere from 10,000 individuals per day are becoming 65 years or older for the next 19 years. So what that says that we'll be increasing our aging population, and while you're aging, you'll also have these age-related diseases that will be coupled with it. Because of that, we will have an increased demand for physician services, and especially for specialty services. But I must tell you that the specialty services will be in dire need because we have not grown on the same level as our primary care doctors. And you probably ask, why did that happen? Well, there's a lot of legislation that has been enacted since 1910 when we had the Flexner Report. But there are three public policies that are very, very important to why we're having a problem with specialties. The first was in 1980 when we had the Graduate Medical Education National Advisory Committee. They stated that at the end of approximately the year 2000, we'd have a plethora of about 70,000 physicians. That means that we would have a surplus of 70,000 physicians. And then in 1994, the National Council on Graduate Medical Education stated that there would be a deficit of 35,000 of primary care physicians and approximately 115,000 increase in specialties. When you couple both of those studies together, it led to the emphasis in the trend in medical school training, in which primary care got primary emphasis and they de-emphasized training in specialties. Then on top of that, we had the Balanced Budget Act of 1996 and 1997, which capped training for graduate medical education at 100,000 individuals each year. So when you put all that information together, where you had the Graduate Medical Education National Advisory Board, you had the Council of Graduate Medical Education, and this cap, it has led to a decrease in specialty training. What we're looking at approximately right now, we have approximately 16,000 active ophthalmologists in the United States right now. Of the population, that's about 5.5 per 100,000 that we have ophthalmologists. Now, it's been put forth that even if we were to increase ophthalmology by 20%, we will only have a 10% increase in ophthalmology physicians by 2 decades. This study was done by Paul Lee and Dr. Parks, in which they showed that even if we had an increase in training in ophthalmologists, there will be a shortage of ophthalmologists. So that leads to the problem we have right now. How are we going to have specialty training, and how are we going to even the playing field? Well, I think the report that was done by 2008 by the Association of American Medical Colleges has stated quite clearly. The workforce is going to have to change, and there's 12 recommendations they make, but I will only stick to the 2 recommendations that are germane to us. The first one is that we need to increase the graduate medical education by 30%. And to accompany that, we need to have an increase of 30% in graduate medical education postgraduate training to accompany those increases in the medical school training. Also, we would like to see rescinded in a 10% cut over 10 years by this current administration to the training of graduate medical education. So In short, I don't want to just keep giving you numbers. It's a dire need that we need more specialists. And we have to, as going forward, we have to make sure that the emphasis in training specialists gets equal footing as the individuals that want to go into primary care. And those are my comments.
Thank you, doctors. At this point, please feel free to ask your questions. Would ask that you provide your name and affiliation just so that our panelists are familiar with who you're speaking.
Good afternoon. Thank you for all of your work and all of the information that we have been waiting to hear. My name is Liz Tronick, and I am the CEO of Macular Degeneration Foundation. My primary concern as an advocate is to be able to help people when they have questions. One of the questions I get is, will a doctor only be able to take a certain percent of their clientele on Medicare? The second, of course, is, will a doctor be able to just decline a Medicare patient altogether because of the cost factor? Is that anything that you can address?
Well, I'll take the first half and I'll pass to Mike the second half. And if you could restate your first question just so I know I've got it right. Your first question?
The first question is, will a retinal specialist ophthalmologist be able to only take a certain percent of Medicare patients, for example, a third or two-thirds because of the cost factor, and or will they be able to turn down a Medicare patient because they simply do not accept Medicare? Is that going to be something that people are going to have to deal with?
Well, I'm a retinal specialist, and so I think what's behind your question in part is not just the economic side of it, but the fact that macular degeneration is becoming an increasing part of every retina specialist practice. And one of the reasons for this is the fact that after decades of not having effective treatments for this disease, we now fortunately have multiple effective treatments, not ideal treatments, but effective treatments for a lot of patients with this potentially blinding disease. And that effectively using those treatments can literally fill an office sometimes, because as I know you know, and many of you may know, many of the drugs that are out there that are effective for macular degeneration have to be injected into the eye according to the studies, sometimes as often as 10 or 12 times per year per eye. And that can create an entire new treatment burden for the ophthalmologist as well as the patient. And in recent years, the payment margin for the treatments has narrowed substantially. Now, having said that, I honestly don't know of a single retina specialist who has said, I'm not going to take care of Medicare patients with this disease. They are Medicare patients, almost by and large. And I think that speaking for my colleagues, we all feel a tremendous obligation to our patients. And so the issue for the ophthalmologist is not going to be so much decreasing access for those patients, but trying to put in place systems in the office in order to handle this large group of patients and still being able to meet the needs for access to care of the entire population of retina patients, diabetics, etc. So I think the issue is not so much a restriction of access as it is for an issue of putting systems in place to manage this. And Bob, perhaps I'll ask you to comment on that. Dr. Copeland is also a retina specialist and manages a very, very busy practice.
I'm a cornea specialist.
Oh, sorry, I was thinking.
Don't worry about it.
That's okay, I was thinking of somebody
I
else.
agree with every comment that Dave made.
So let me interject, though. But what you ask is, in fact, what we see in primary care.
Exactly.
That there can be decisions made by practitioners because of their margins that they will restrict to a percent or will close their practice to Medicare patients. That would be within the realm of possibility. It's not illegal to do that. And So we could conceive of that happening, that some practitioners could do that. So it's not an illegal situation. Obviously, if that was to become widespread, that then becomes an access problem that the beneficiary population, which you're in part representing, would be advocating quite vigorously on, and we certainly would encourage you to lobby on in terms of making sure that we have access with fair payment.
Yeah, and I think just to sort of come full circle on that, the issue, our goal is basically to provide access to care. And as Mike said, advocacy is a critical part of this. But as Mike said, you could get to a situation where you have people very legally opting out of Medicare. That's perfectly legal. Our goal, however, is basically to have systems in place to not allow